In the name of the Almighty, most merciful and beneficent. I have shown you the X-rays previously. 5 X-rays in this section. Now the interpretation of these 5 X-rays, their answers. I am Professor Sayyid Ali Haider, and I am the facilitator online for these X-rays. Basically, I am internal internist. My field of interest is actually clinical cardiology and related subjects with the cardiology which is associated with this, and clinical cardiology associated with the other systems as well. And the first X-ray was given to you, a 28-year-old cement factory worker developed cough with expectoration and escalating shortness of breath. You know, he's a factory worker and he has got NIA, that is New York Heart Association classification. The class, he has 2+ breathlessness. The interpretation is that this X-ray plain chest which is done and all parameters have been checked from every angle, starting from the requirements till the hyla. Now there is nothing significant seen in the other markers for the X-rays or parameters of the X-rays. Now here, what is important in this condition, at this age group, he has got this problem. The problem is seen in the lung fields. Trachea here is going on like this. The upper zones with the upper zones, the first intercostal space with the first, second with the second, third with the third, fourth with the fourth. In this fashion you go downwards. And then you see the costophrenic and cardiophrenic angle in the dome of the diaphragm. And this is the middle mediastinum cardiac shadow. Now here you see in this condition that there are this is this, which I am marking here. This is the fibrotic patches are seen, bands, shaped like this, cystic type, you can say, a bag-like, something like this. You can see the fibrous bands here. Here there is marked one. It is a more hyperdense shadow. Plus, the dome of the diaphragm, here you see this linear striations, which is hyperdense shadows here, and here, obscuring it's actually the curvature of the lungs. As middle mediastinum is concerned, the left and the right heart borders, they are not obscured completely by these fibrous thick bands. And there is hypertransparency inside, means compensatory emphysema is there. Aortic knuckle is more prominent in this age group. Now she developed this. Why? Because she was a factory worker, cement factory worker, and the position is this. The findings which I have just told you describing the differential diagnosis. Acute inflammation, no, it is not a result of the acute inflammation. Or chronic inflammation, yes, probably. The patient had developed previously the tuberculosis and it results in the fibrotic patches, patchy opacity that is called. Possibility is there. Some of it is calcified. And then the other fungal infection can cause the banded appearance. It is possibility in certain countries. For example, the streptococcus can cause this type of bleaching if it is prolonged stay for the exposure for this fungus. Or histoplasmosis can do it. Now, another differential diagnosis can be made. Some of the autoimmune diseases present like that, because there is the hilar shadows are prominent, and there is the very hilar or hilar linolopathy associated with it, with maybe the lesion which is related with the sarcoidosis. And what is called the interstitial group of lung diseases, yes, it is. And what is caused is the pneumoconiosis, because it's a fatty worker. Which pneumoconiosis can cause these of the fibrous bands, sac-like, and these are called the plaques. Pleural plaques are there. And there is only one condition in which it occurs, and that is asbestosis. Can cause this type of picture, not the other pneumoconiosis. This is the differential diagnosis first, and the final one is the asbestosis, most likely. The asbestosis can be diagnosed on the skygrams. Lateral view can be done. The HRCT will confirm it in the plaques. Other than that, it will be found on the lateral wall. The plaques are important precursor for the mesothelioma, and mesothelioma is a precursor for mesothelial carcinoma. So it is very important in this condition to suppress it as soon as possible. Other investigation can be done, like sputum for the AFB and DR, culture and sensitivity. You can do the pulmonary function test. You find the disease is, of course, restrictive in nature. Look, the first rib, the second, the third, is hardly fourth rib. Patient cannot inspire so much. It is a restrictive pattern as seen, and the intercostal spaces are wide enough. They are more than 2.5 centimeters at the mid-clavicular line. All are justifications of the restrictive lung disease. The most commonest restrictive lung disease is ILD. In the ILD, associated with the environmental exposure, the type of the findings favoring the asbestosis. So like LFT and UC and other investigation should be done to monitor the other system as well. So how will you confirm it? You take the biopsy and confirm it. This is the direct evidence. And then you will go for the treatment. Treatment is the avoidance of the exposure. You should be out of this. Very necessary, she should wear the masks. Oxygenation should be given to her, intermittent oxygenation, physical therapy, chest physiotherapy, and the drugs which can expectorate, which causing the expectoration as much as you can, postural drainage, but it will end up in the bronchiectasis afterwards. If you prevent it from the factory works, and avoidance of this asbestosis, it's a possibility that these plaques will not be converted into mesothelioma. Otherwise, you give the bronchodilation, and steroids will helpful in this condition. Next one was a 52-year-old non-diabetes mellitus was attacked by a sudden fever. It is very, very sudden. It is dramatic appearance of the fever, the chest pain, productive curve with a current jelly consistency, and very due space time is very short. Now this is the X-ray which was done, a frontal projection. EP sitting written here, and the patient was interpreted, all parameters is seen here. This is the trachea, which is going on here, and look that the first intercostal space and apicus, compare the lung fields space-wise, intercostal space-wise. You see, this is the lesion which is here up till there. It is a non-homogeneous type of the radiopacity from here to here. The air bronchogram pattern is seen here, till here. The second means the mid zones and the lower zones are involved on the left side. And it is not masking the shadow. Silhouette sign is not positive. So it is a limited one in the lung. And the pleura is not involved in this condition. If the pleura is involved, the silhouette sign will be positive. Now, depending upon the findings and the scenario, I will do the left lateral view. I will go for HRCT, and I will go for the sputum AFDR, culture and sensitivity, AFB, gene expert. As a routine, I have to do it because it's very short history. But definitely, it is not the chronic inflammation; it is acute inflammation. So it is the grey polarization which I see. I mark it as a grey polarization of the lobar type of pneumonia, but it's lobar pneumonia which is of this type. The air bronchoban pattern seen, very quick, stages of the consolidation is seen in this. And the other investigation you could do is the CBC and the LFTs, the acute phase reactants, and the urine REN for the pneumococcal antigen. The favored sign will be positive here, not for the pneumococcus, rather than the other bacteria, which will be a gram-negative type of bacteria, probably. Now, this is the lesion. You see is what is called is the Klebsiella pneumoniae will cause it, which is actually commensal in the nose, but it is pathogenic in this state. And it is called Fred-Leller's pneumonia. Productive cough, very, very short duration of consolidation, resolving very, very quickly, and very high, constitutional symptoms with the current jelly consistency sputum. So you go to the management as antibiotic specific should be given. For gram-negative coverage, strong coverage. Milipinams, azithromycins, macrolides, the gentamicin, the caramycin, aminoglycoside groups, yes. And other general measures should be done. Bronchodilation, oxygenation, and other means. A 55-year-old smoker gradually developed escalating dyspnea. Escalating dyspnea is cough and expectoration, 55 years old. Now this disease is caused by, here is the trachea, which is central. The other parameters are fulfilled here. And you see the pitchy type of obesities here and here and here and here and here, in all lung fields. Crossover bridges, these are not bronchoscopic markings, but these are the fibrous bands, and they are crossed over with each other. So the tenting of the dome of diaphragm is visible here. You can see in this here, it is this one. What is called pleural thickening in our terminology. There is also tenting of the dome of the diaphragm. And another feature is this one. The pulmonary conus is more prominent. The pulmonary conus is more prominent in this condition. What is the disease? Is a chronic escalating disease. It may be acute inflammation or the result of the acute inflammation, no. Chronic inflammation is possible with tuberculosis, pitchy obesity, crossover bridges, honeycombing effects are seen. Yes. Fungal infection can cause it. Yes. And then we go for the other diseases about the tumors and the tumor-like state. No, this type of picture is not seen usually. The allergic conditions like the hypersubliminaitis can cause this condition. It is possible. But you have to exclude it and then go for the interstitial lung diseases are concerned. Yes, they can cause these type of pictures, no doubt. ILD is a very, very diverse type of a diagnosis, very, very broad. They are excluding actually. You go for the other investigation, sarcoidosis should be excluded in this condition as well, because it also causes the fibrosis. Now, doing the HRCT and doing the sputum DR examination with AFB, exclusion of the tuberculosis, go for the other routine clinic investigations. Ultimately, you have to do the biopsy because it is not fitting into anything. Patient has got the malaise and he is losing weight, anorectic, irritable patient. Usually this disease is usually seen at the age of 25 to 30 years, but now he is 55 years old. The disease was previously present. It is gradually escalating, escalating. After biopsy, you can go for the other interstitial lung diseases, which are rare diseases. It is a histiocytosis X. It's called Langerhans cell granuloma. It is only diagnosed by the biopsy. The management strategy, again, the chest exercise, the oxygenation, the bronchodilation, the non-specific measures. One should try, because disease will be going and it will destroy the lung. The salvage therapy is that you have to give the vinblastine plus prednisone should be given in this condition, and marcaptipurine. Tried vinblastine plus prednisone plus marcaptipurine. And this is the actually studies done in many countries by these triple therapy. But they said it is autoimmune nature of this disease because multiple systems are involved. The lungs are the target. Otherwise, you have to go because the pulmonary hypertension is developing. It is more than 45. You can't do the surgery. Before this, you can do it. Otherwise, you have to go for the cardio transplantation with the lung transplantation. To avoid it, the drugs which reduces the pulmonary hypertension should be given to this patient. A 32-year-old was salvaged from the drowning after initial resuscitation, admitted in ICU. Now here in this case, you see the all lung fields. It is portable X-ray underlying position in the bed where the oxygenation and the ventilators, the all things are exposed here, the monitors. All lung fields are involved. Nothing is left. And there is increased haziness, which is described as non-homogeneous radio opacities. And these opacities are in the banded structures. Fibrous bands are seen all over, thick fibrous bands. And patchy opacities, reticulonodular shadowings are also there. Full lung fields, whole lung fields involved. And clinically, if it describes the ratio of the SiO2 with the PO2, then you can classify it as ARDS or acute lung injury, or in between the two. Because after drowning, this case usually occurs like this. Actually starting in the bronchopneumonia, and it is causing a severe reaction in the lung. So this is the case of the ARDS. The other investigation HRCT can be done in this patient, sputum can be done in this patient, the CBC, the acute phase reactants, the LFT, UC, all should be done. And this patient can be saved by on ventilation, because he's going into the respiratory failure type 2. The PEEP is the more positive and expiratory pressure. Maintain it, to avoid the secondary infection, give the broad spectrum antibiotics unless it is resolved. A 18-year-old non-smoker with a deranged LFT is presented with escalating dyspnea. Now this question was asked by me in the fellowship examination. This is probably the same X-ray. They mounted at one time. There was a viva, table viva. I explained that X-ray, that this is the X-ray, and all the trachea, aortic knuckle is prominent, the perihalar shadows are very, very visible, markedly visible. Lower down, this is the lower branch, the upper branch of the hara. But to me, the all lung field, the bronchovascular markings are very narrow, very narrow, rather. And there are increased transparencies in the lungs, hypertransparency. Now she was the lady and had this type of the problem. Associated, okay, it is emphysema, severe, okay, on both sides. Predominant emphysema is seen, COPD as a part of COPD. But is it called LFT is deranged? Means something has been done actually in this patient to justify our diagnosis. There is possibly the alpha-1 antitrypsin deficiency can cause the LFT derangement, going for the chronic liver disease or chronic hepatitis type of a lesion or cirrhotic at one time associated with emphysema. This is not hepatopulmonary or pulmonary hepatic syndrome. No. Actually, this is deranged LFT with escalating dyspnea with emphysema bilaterally present, gradually escalating. So this is the case of the alpha-1 antitrypsin deficiency, which should be diagnosed by the deficiency of alpha-1 antitrypsin in the serum. Confirm it. And the management is as the emphysema you have to give. And the smoking, he's a normal smoker, but passive smoking should be avoided. Environmental exposure to the teaching should be avoided. Good oxygenation, physical exercise, physiotherapy, and the management, because to prevent the pulmonary hypertension in this condition, the primary prevention should be done. Ultimately, it will be good into the pulmonary hypertension. Where the liver is concerned, try to manage the liver problems accordingly as we go for the chronic hepatitis unknown, or where there is no viral infection and there was the chronic hepatitis. To avoid it further progression, we give certain preventive medications. Now this is how we can explain in a very short time. Time is short, and that is why I brief like this. So this is the end of the session, and all exercises are explained by me in a brief time. I hope that you have matched your answers with this, although few exercises are very difficult. But if the findings are good, you correctly written the findings, I will give you marks, 7 marks for the findings, 3 marks for the diagnosis and differential diagnosis and management. So we'll see you with the other part of the session of 8th session. Very, inshallah, after one day I will do it. Until then, goodbye. Good luck for your examination.